to, let's say, more or less integrate the two talks that you just had, but I will try to do it talking to you. Because the problem is not the blood pressure, the problem is not the cardiac output, the problem is what does the patient need. And so identify your clinical problem, identify how to deal with the problem, and then find the right treatment. Now that's complicated because what's really the clinical problem? What's the clinical window to define your clinical problem? So in rats and in sheep and in pigs, it's always very easy. But once you go to the bedside, we are extremely limited in how to assess adequacy of blood flow, adequacy of blood pressure, or whatsoever. And so that's the challenge. And what Daniel just said is more than true. Every patient probably needs different parameters or different levels for blood pressure. So in my view, every patient is an N-is-1 experiment. And what I will try to explain to you is how do you or could you assess the problem, think about the solution, and what is the place of inodilators or vasodilators in this. Well, as you know, the use of inodilators, vasodilators, especially because we are so afraid of low blood pressure, has a lot of emotion when you talk about it in conferences like this, because many think that vasodilators are counterintuitive in patients with already low blood pressure, that vasodilators cause severe hypotension, that they require a lot of fluids to, let's say, restore the effects of the vasodilation, and that vasodilators cause severe tachycardia in your patient. Now, I will try to deal with many of these aspects in the next slides. The problem with assessing the role of flow and pressure is that we have a very strange, in general, a very strange idea of the microcirculation. And many think that the pressure in the aorta and the flow that's coming out of your left ventricle is immediately transferred to, let's say, the gut or the kidney or the muscles or whatever. And that so increasing pressure here will increase pressure here, and so will increase the driving pressure over your microcirculation, so an increase in blood pressure will improve the microcirculatory perfusion. That's generally what we think, and that's mostly the discussions we have with surgeons, neurosurgeons, and cardiac surgeons. But that's not true, because we usually leave something out in this perspective, and we leave out something that Danielle already mentioned, the precapillary sphincters, the Starling resistors. And think about how you, as a, let's say, more or less healthy individual, maybe DJ, he's old and he's not that healthy anymore, but if you're more or less normal, do you think that you alter your blood pressure when you need more microcirculatory perfusion? When you exercise, that your blood pressure goes up in order to improve flow in your muscles? No, you open up your precapillary sphincter. That's the reason why you can walk and do marathons and stuff like that. Not because you increase your blood pressure. Nobody increases his blood pressure to guarantee microcirculatory perfusion. That's not the way in normal physiology it works. In normal physiology, we open up the sphincter. And so we use vasodilation in order to improve microcirculatory blood flow. And when you open up the microcirculatory sphincter, of course, you get more flow. The result is that if you improve the state of this vasodilation, so you have more vasodilation, you have more flow in the microcirculation, you have more flow coming out of the microcirculation, and that's why your cardiac output increases. Your cardiac output does not increase because you exercise, but because you have more venous return. That's the normal physiology. Oh. And if you Daniel already showed this cartoon, I will adjust it a little bit to make you understand what problems that we have in clinical practice and what way of intervention we could choose to optimize microcirculatory perfusion. This is the normal state of your microcirculation. You have your aortic pressure, and the pressure falls to the entry of your microcirculation, and this is after your Starling resistor. The problem is we cannot measure this pressure. There is no way, at least in patients, to measure this pressure. But what happens if you have vasoconstriction is that despite there is a small increase in blood pressure, we all know that trauma patients with severe bleeding come to the emergency room with increased blood pressure. When they come with very low blood pressure, it's already a faraway state. So in the beginning of hemorrhage, in the beginning of hypovolemia, you increase your blood pressure due to the vasoconstriction, and the net result is a decrease in microcirculatory perfusion. That's why these patients are cold. That's why these patients have a clammy skin. They have this underperfused skin with mottling score, like the very nice studies from France that show the relationship between mottling score and mortality. That's why you have this decreased microcirculatory perfusion, because the entry pressure decreases. If your Starling resistor constricts, then the pressure following the Starling resistor will decrease, obviously. And so the entry pressure of your microcirculation falls, and that's why you have this abnormal microcirculation. When you then have vasodilation, so when you open your Starling resistor, you may decrease your mean arterial pressure. Absolutely. In some patients you will have somewhat more, but in others somewhat less. But there is some form of decrease in mean arterial pressure. But the net effect is that the pressure, entry pressure of your microcirculation increases. If your Starling resistor opens up, then the entry pressure in your microcirculation will increase. So vasodilation, even in a state of hypotension, can be associated with an increased microcirculatory perfusion pressure. The problem in clinical practice is that if we have this hypotension, and if we have this increased entry pressure of your microcirculation due to the vasodilation, sepsis, spinal shock, all these circumstances, post-cardiotomy shock associated with a lot of vasodilation, it's more or less this state. You have significant mean arterial pressure, hypotension, and you have increased perfusion pressure over your microcirculation due to the vasodilation, but the problem is we have venous constriction as well, or we follow the surviving sepsis guidelines and we increase the central venous pressure to 12, thereby decreasing the net perfusion pressure over the microcirculation because we increase this pressure. So despite this beneficial effect, we lose the beneficial effect by increasing the venous pressure. Now, I'm to talk about inodilators. Is there a beneficial effect of inodilators? I think studies like this do not help very much, because this is a study looking at inodilators or a combination of inodilators and vasopressors, and this is thinking in this old concept of blood pressure and microcirculatory perfusion and offloading of the heart. And although there is an association with, if you have a combined regimen, that mortality is decreased, so better survival when you compare the pressors versus the inodilators, that doesn't help you in clinical practice. Would you add an inodilator to every patient in cardiogenic shock, even if he has no problem? Like Chanincha told you, if your microcirculation is normal, why do you need to do anything? What would the patient need with a normal microcirculation? So studies like this maybe help you to be more sure that it's not very bad to have some inodilator-associated hypotension, because overall these patients do more or less okay. That's not really helpful in clinical practice, because we would not add anything standard to the treatment of these patients if there is no clinical problem. And if you want to solve the clinical problem, then define it and find the best solution. And of course, studies like this only give you, well, it's either too much vasoconstriction that is not beneficial, or the excessive vasodilation is beneficial to explain this result. Doesn't help you in clinical practice. And if you have a clinical problem that could be solved with an inodilator, when you have a tormented heart, just like in this Mentu syndrome, where the patient came in with severe hypotension, 60/30, and see this undulating, this sinus rhythm in the blood pressure going from 280 over 140 to 60 over 30. There was no microcirculatory perfusion, as you can see here. There's hardly any perfusion here. By offloading the heart, by opening up the periphery and limiting the vasoconstrictive effect of this pheochromocytoma, we could greatly improve the microcirculation just by bolusing. And this is bolus, real. So 100 milligram, boom, into the patient. And of course, the blood pressure was off the scale for some time, but the sinus rhythm in the blood pressure completely disappeared. It restored cardiac output and blood pressure. So if you have a clinical problem that could be, and the patient could benefit from an inodilator, yeah, then please use it, but not in a standard way. And if you have a patient, and if you think that vasodilators are beneficial, then probably not for every patient. Patients that need it might benefit, but patients that do not need it might have negative effects. And this could be the explanation why Christian Boerma in Leeuwarden found this result. When he added nitroglycerin to every patient, he found that it did not affect the microcirculation at all. And if anything, the mortality in the nitroglycerin group increased instead of decreased. Where we, in our lactate study that we published in the Blue Journal, where we mandated the use of nitroglycerin when lactate did not come down, and so 40% of the patients used nitroglycerin, we had a 20% increase in survival. Instead of a decrease in survival, the use of nitroglycerin was associated with an improvement in survival, but only in patients where we had a clinical problem that we thought could be dealt with by adding a vasodilator. And if you have patients with inadequate cardiac output and you add dobutamine to this group of patients as a standard protocol, like Jean-Louis Vincent in the early days showed in critical care medicine, adding a inodilator to a standard protocol of resuscitation, if your baseline SVO2 is abnormally low, yeah, these patients, more or less, most of these patients will benefit. That makes sense. And interesting in this study is that in the patient that had a drop in blood pressure, that's this group of patients, the inodilator decreased right atrial pressure. So despite the fact that you had a drop in blood pressure, there was a decrease in the venous pressure, and venous pressure is post-capillary pressure. So yeah, these patients could maybe have a double beneficial effect on the microcirculation, despite the fact that their blood pressure fell. They had an increase in cardiac output, they had a decrease in post-capillary pressure. If Jean-Louis would have had the microcirculatory scan at that time, could have maybe found a huge improvement in the microcirculation in these patients. DJ already asked about the importance of central venous pressure. When we had these fierce discussions with our surgeons on the best blood pressure in gastric tube reconstruction, and we said it doesn't make any sense to increase blood pressure to improve perfusion of this gastric tube. You have to improve microcirculatory perfusion, and blood pressure is just one aspect of that. Of course, maybe very severe low blood pressure will limit microcirculatory perfusion, but it's the perfusion pressure over the microcirculation. And when Jasper van Bommel from our department, together with the surgeons, did a pig model of gastric tube reconstruction, and he manipulated the blood pressure from 50, that's very low, to 110, that's very high. And he did this with norepinephrine and propofol. He showed that when you added a vasodilator to this regimen of very low blood pressure to very high blood pressure, the blood pressure in and of itself had no effect whatsoever on the microcirculation. And this is in the fundus, we measured in all regions of the gastric tube, no effect on any of these regions. But if anything, the microcirculatory perfusion was always best in the animals treated with nitroglycerin. Why? No effect of blood pressure, but in the nitroglycerin-treated animals, the open bars, central venous pressure was always significantly lower. So whatever the blood pressure, at least in this model of gastric tube reconstruction, post-capillary pressure is more important in the determination of microvascular blood flow than the blood pressure in and of itself. And when we look in cardiac failure, Korstian den Uyl did a dose titration of nitroglycerin and measured the perfusion under the tongue, he saw a very nice relationship: more nitroglycerin, more microvascular perfusion, turn off the nitroglycerin and go back to baseline. This was not related to the effect on cardiac output, because even in patients where there was no change in cardiac output, in red, there was a dose-dependent increase in microcirculatory perfusion. So it was not related to cardiac output. It was not related to blood pressure, because if anything, blood pressure fell significantly from 77 around to around 65, so a significant decrease in blood pressure. So no change in cardiac output, a drop in blood pressure, and an improvement in the microcirculation. Why? We think because we had a huge decrease in central venous pressure, post-capillary pressure. It went from 11 to 4. That's a very, very significant fall in post-capillary pressure. So despite the fact that there was no change in overall blood flow, despite the fact that there was a drop in mean arterial pressure, there was a significant improvement in the microcirculation. The lower the CVP, the better the perfusion of the microcirculation. And this fits in the model of my first slides. And the group from DDA already showed that indeed this post-capillary pressure can be a very important determinant of organ failure. In this case, they looked at kidney failure, venous pressures around between 8 to 12 already had a significant increased incidence of acute kidney injury, just like the study from Wellinga from Leeuwarden, who showed more or less the same. At the CVP of 12, you're at risk of decreased microcirculatory perfusion, whatever the blood pressure. And if you have this abnormality in microcirculatory perfusion, you can indeed improve the microcirculation, or as Alex Lima from our group showed, completely restore all abnormalities. This is a study that he just published in Critical Care. All patients had abnormal microcirculation as assessed by the periphery. All had a drop in blood pressure, no increase in heart rate, no change in cardiac output, and a complete restoration of all the parameters that he used to assess abnormal microcirculatory perfusion, either by capillary refill time, perfusion index, skin difference, STO2, or the upslope that Daniel also already referred to. If you titrate nitroglycerin, you completely restore all the parameters. When you turn the nitroglycerin off, the effect is gone. And that's why Martin Dunzer, Yuka Takala, and Andreas Bernauer and me, we wrote an editorial that we should move away from the macrohemodynamics, from the cardiac output, from the targeting central venous pressure, from the targeting to cardiac index and oxygen delivery. We should move to microcirculatory perfusion. And we should use microcirculatory perfusion as the endpoint of our resuscitation efforts. And if your microcirculation is normal, as John Inch already said, and Daniel already said, if the microcirculation under your tongue is normal, maybe you could stop resuscitating. We just finished a study where we used the microcirculation as the endpoint of fluid therapy. So if the microcirculation was normal and you had a clinical problem, you were not allowed to give fluids. Resulted in a 10-liter less positive fluid balance. And so we should move away from macrohemodynamics to microcirculation, and if the microcirculation is normal, and only if, then you would maybe be able to allow hypotension. So in conclusion, the goal is to have adequate circulation, like John Inch said. To deliver adequate oxygen to tissues and, of course, other nutrients, and to remove waste products. And this is a reason to use maybe the arteriovenous CO2 difference. Inodilators may offload the tormented heart. There's no question about it, by decreasing the afterload, but should ultimately result or contribute to optimizing blood flow by efficient myocardial oxygen balance. Absolutely true. Improving the microcirculatory perfusion is an important element in optimization, Never forget that. And hypotension does not, by definition, worsen the microcirculation. Very important to recognize. Decreasing central venous pressure contributes to improve microcirculatory perfusion. And I think inodilators fit in a strategy to optimize adequate perfusion. Thank you very much.